Hi guys, good evening, good evening. Can you all hear me? Can you all see me? Alright guys. Wait, let me access the chat box. Yeah, hi Sandeep Sarkar. Good evening, good evening. Right, so yesterday, as we all know, we started with the esophagus. We went through the basic anatomy of the esophagus, and we just went through the all important aspects and the concepts that are required for us to understand the esophageal anatomy. We talk about wall, we talk about division, every single component, right? Now, as I told you, you have understood the whole component of the esophagus. Let's quickly run through one of the small videos which we're going to talk about is about the upper GI endoscopy. So before we move on, I wanted to have an inner look of how an endoscope looks. So just give me a second. Okay. Right. So some technical issue. Echo is happening now. Is it okay now? Is it okay, guys? Is it audible? Is it okay now? No. Okay, wait. Just give me a second, guys. Okay. Is it fine now? Yeah. Can you all hear me? Is the audio fine now? Quick feedback. No, still not. One second, guys. Can you all hear me? Is it fine? Hold on for a second, guys. Just give me one second. Yeah, I know there's some audio issue. Just give us a second. The team is working on a backhand. Just give me a second. Hold on for a second, guys. Check. Is it okay now? Is it okay now? Can you all hear me? That's okay. Okay. One second, guys. Okay. Uh, yeah, I think it should work fine now. Let's take a leap. Right. So, as I was saying, we'll run through the basic video of an upper GI endoscopy. Yesterday, we learned about how, the various components of the esophagus are there. So, today we'll try to see them on an endoscope and try to analyze, right? Now, you can see the first part of it. Right. So, as you can see across here, initially, you can see this is the tongue. We're going into the oral cavity. And yes, right across there, you cross the uvula. About that, yeah. And then we'll sweep in a little bit in here. And this, so this is where you can see the cricoarytenoid cartilages are there. They open inside. You have the vocal cords. These are the vocal cords. We're not supposed to go there. We have to go under the cricoarytenoid cartilage, lift the epiglottis, just go under it. Yes, we're going to sweep it down. Now, as you enter, you would be able to see that the esophageal lumen is going to open up, right? Now, as you can see, the lumen is opening up here, and we gently move across. We cross the cervical esophagus, go into the thoracic esophagus. As you continue to go in, you'll sweep in a little bit. As you can see, every time you in, because the esophagus is in a collapse state, you have to gently inflate it, make your way into it, and you continue to go. And this, you're going into the lower part of the esophagus. Now you can see that Z line. Yes, that's the transition, that is red and pink, right? So this is the transition. This is a lower esophageal sphincter, and bam, I'll exert a little bit pressure, and now I'll go in. The minute I exert pressure, I'll open a little bit more extensive pressure. You have to center your scope. Once you've centered it, you try to open it a little bit. Now, as you open it, yes, now you have gone into the lumen. Should be opening now any minute. Just sim. There. Now you are into stomach. This is the gastric rugosities, all the gastric secretions, and now you are inside the stomach, right? So if you look at the entire video, you can see how it is tunneled. So every single time I talk about the upper GI endoscopy, you know what I want to do. I want to go into the lumen. I have to see the entire luminal wall. I have to see the sphincter. I have to see any changes. If there is any mass, I can take the biopsy. I can visualize. Everything will be dead spot on. You will be able to look through. So that's the magic of your upper GI endoscopy. Is that clear? Chalo. Now, if you have gone through the upper GI endoscopy, let's continue our lecture. So today, we're going to start with the basic topic. As I said, we'll start with one individual topic and then we'll continue to move. Today, we'll be talking about one of the congenital disorders of the esophagus, and that is going to be your tracheoesophageal fistula. So today's opening topic that we'll talk about in a congenital disorders is what is popularly referred to as the TOF. It is not the tetralogy of Fallot. It is the tracheoesophageal fistula. It is the tracheoesophageal fistula. When we talk about tracheoesophageal fistula, now as we all know, fistula means an abnormal communication. So whenever you say the word fistula, the fistula basically means it is an abnormal communication. It is an abnormal communication between, it is an abnormal communication between two lumens or a lumen and a cavity. Either it is communicating between two lumens or it is communicating between a lumen and a cavity, and this is what we call it as the tracheoesophageal fistula, right? Now, in order to understand the whole concept behind the tracheoesophageal fistula, I'll give you a basic pathophysiology of what embryonically would have happened. Now, this entire divisional segment is going to develop from the embryonic primitive state, and this is what we call it as a foregut. So this is the embryonic foregut that you have. This is the embryonic foregut that you have. Now, during the development of the embryonic foregut, you will see that this foregut will be divided by a septa. There will be a septation that is going to be created, and this will divide them into two components. You have the anterior bud and the posterior bud. The anterior bud is what we call it as the tracheobronchial bud or the respiratory bud. This is what we call it as the respiratory bud, or also called as the tracheobronchial bud, also referred to as the tracheobronchial bud. And this happens to be the luminal bud, which is going to develop into esophagus. We'll call it as the esophageal bud. Now, as the embryonic development continues to happen, you will notice the common area will be of your cricopharyngeal status, which is going to now divide anteriorly into the tracheal lumen, and posteriorly it is going to continue into the esophagus. Now, this tracheal lumen will further go and divide into the right and the left main bronchus, and this right and the left main bronchus will now give rise to the lung, and this is how you will see the components are going to be developed, right? So this, on the other hand, will continue to form into the esophagus, and then this crossing the diaphragm will go into the stomach, right? So you can see the anterior, this is the common channel. This happens to be the common channel between the two. This develops into the tracheobronchial sea. So this is trachea, this is bronchus, this is lungs, and this happens to be esophagus. This happens to be the esophagus. So this is what we've been knowing, that from the primitive foregut, it is going to develop into two components by a divisional septa, and from the septal component, it is now going to divide, or it is now going to form. It is now going to form into two components. One is going to be the tracheal component, another one is going to be the esophageal component. Now the whole game is, if this septa which is formed, it is incomplete. Now, is it either because of an incomplete or improper septation? Either it is because of an incomplete or an improper septa. Either it is because of an incomplete or an improper septation. This will result in a condition which is called as the tracheoesophageal fistula. There's another disorder that is going to be associated with, that is going to be esophageal atresia, right? So as a note point before we move down, we say all patients of tracheoesophageal fistula is considered to have esophageal atresia until proven otherwise. Until proven otherwise. What do you mean by this? It's a simple concept here. When I say the word atresia, it is an incomplete or improper channelization between two lumens. It fails to form a continuity. Now, that can be because of an improper septation. Now, as I say, the tracheoesophageal fistula, all patients who have a tracheoesophageal fistula will be considered to have a esophageal atresia until unless proven otherwise, right? Now, this is a very, very important concept to understand that. Now, based upon this, we have different types of the tracheoesophageal fistula. So let's talk about the various types of the tracheoesophageal fistula. What are the different varieties of the tracheoesophageal fistula that we have? The first one is your type 1 variety. Now, the type 1 variety, or also called as the type A variety rather, the type A variety is what we call it as A for atresia. Now, type A variety is what we call it as the atresia form. It is an atresia form. Now, what do you mean by an atresial form is, you will notice that if this is the trachea is going to be absolutely fine. This is the carina from where it is dividing. This is how the trachea is going to look across, right? Now, behind the trachea, you have the esophagus, which is going to be present. Now, interesting thing about the esophagus here is, it is going to have atresia. This is the upper esophageal lumen, and the lower one, it fails to channelize and continues into stomach. And if you have a presentation like this, where you have an esophageal atresia, this is what we call it as the type A variety. This is what we call it as a type A variety. Then we have something called as the type B variety. This is what we call it as a type B variety, where you have an esophageal atresia, where you have the esophageal atresia with upper esophageal fistula or upper tracheoesophageal fistula. You have the upper tracheoesophageal fistula. Now, what do you mean by this? Again, the same depiction will be there. You will have the trachea, which is absolutely fine. This is going to divide. This is going to divide into the tracheal rings in this form. You will notice that the esophagus, which is present here, is now going to communicate with this part. So there is an upper esophageal communicating segment. The lower one fails to channelize and it continues into stomach in this form. So you see, this is what we call it as an upper communicating fistula, but the atresia still maintains. That is your type B variety. Then comes the most common variety that we know. It is your type C variety. Now, in the type C variety, here you will have an esophageal atresia. In type C variety, you are going to have an esophageal atresia still maintained with lower tracheoesophageal fistula. The lower tracheoesophageal fistula, so you have the same component here. This time the esophagus, when the trachea is fine, this is where you have, this is the tracheal bifurcation that you have. These are the tracheal rings. These are the tracheal rings. You will notice that the upper esophageal segment will have atresia. The lower one is going to have a communicating channel, and this is how your stomach is going to go across. Soumyadeep, I'll explain you how the clinical presentation would be. For now, let's just concentrate that what are the different varieties of it. We'll talk about what is the clinical presentation, how will these babies going to present to us. But this is the common varieties that you have. A type A variety, you can see that only atresia, no fistula. Type B, the atresia is maintained, the upper communicating fistula is there. In type C variety, you see the atresia is still maintained. Atresia means the esophagus is not channelizing and the lower communicating fistula or the lower esophageal fistula is present, right? That is your the first three varieties. Then you have the type D variety. Now it's quite predictable for us. Now when I say type D variety, in type A there is only atresia, no fistula. Type B there is upper fistula. Type C there is lower fistula. Type D it will have both the fistulas. So here you can see that there is presence of esophageal atresia. There is presence of esophageal atresia with both upper and lower tracheoesophageal fistula. With both upper and the lower tracheoesophageal fistula. So when you understand this, this happens to be the tracheal representation. So this time, this is how the trachea would bifurcate. These happens to be the tracheal rings which are present and they continue to go off across, right? Next you see the upper communicating fistula is here, the lower communicating fistula is going to be here, and this is going to be in continuity with that of the stomach, which is right. So as you can see, the atresia is maintained. This is where you have the atresia is still maintained and both upper and the lower communicating fistulas are formed. That is a type D variety. Then you have something called as the type H variety. We don't call it as an E variety. So just for the sake of understanding, I can just number it as alphabet E, but popularly called as the type H variety. They're popularly referred to as the type H variety. In type H variety, there is no tracheoesophageal fistula. There is no fistula at all. Sorry, there is no atresia at all. It will only have tracheoesophageal fistula. It is what we call it as the pure atresial form. This is what we call it as a pure atresial form. So here you will notice that the trachea would be absolutely fine. This is the tracheal bifurcation that you have. These are the tracheal rings which are present across here. You see, this is the esophagus, and this is how it is going to communicate. There is only a fistulous tract between these two because it looks like the English alphabet H. If you can see here, this looks like an English alphabet H. This is what we call it as an H variety. There is no atresia. It is a pure fistula form, right? Now, another variety that is rare, I mean, lesser common across here, that is type F variety. Now, type F variety is only about esophageal stenosis. This is where you only have esophageal. Here you have the esophageal stenosis. So again, this is going to be the trachea, which is going to be absolutely fine. These happens to be the tracheal rings which are present. And then you see this is the esophageal lumen. And suddenly you will see that lumen will have a narrowing, nothing else than that. And then it will continue off. This narrowing of the esophagus, you can see as this narrowing of the esophagus is present here. This narrowing is what we call it as esophageal stenosis, right? So the type D variety, right? Yeah, the H variety is the pure, I'm saying fistula form. Yeah, I made a mistake here, sorry. It's a pure fistula form. Correct, guys. This is your pure fistula form. Correct. The only fistula, there is no atresia. Yeah. Yeah, guys. I hope it makes sense. Okay. Thoda extensive hai, but I'll just quickly run through it. So when we talk about the types of the tracheoesophageal fistula, we'll talk about the two important components which is going to coexist. One is atresia, another one is fistula. In type A variety, you can see there is no communication, so there is atresia is present, but no fistula. In type B variety, the esophagus is not communicating, so atresia is present, but the upper segment of the esophagus is communicating with the trachea, so it is an upper tracheoesophageal fistula. Type C, again you can see there is no communication between the esophagus, there is atresia, but this time you can see the lower esophagus is communicating with the trachea, so it's a lower esophageal communication or the lower esophageal tracheoesophageal fistula. Now comes your type D variety. Type D variety, you can see there is an atresia that exists, and you can see the upper esophagus, there is the lower esophagus, and both of them are communicating with the trachea. So there is say there are two fistulas, the upper esophageal as well as the lower esophageal fistula. H variety is a pure fistula form. There is no atresia. And the last variety which is there, the F variety, which we call it as the stenosing variety, there is no fistula, there is no atresia, but there is narrowing that we are going to accomplish, right? Of all these varieties, remember the one that is going to present clinically more often than not is going to be the type type C variety. The type C variety is the overall most common type. This is the overall most common type of the tracheoesophageal fistula, and this is how they ask you in your competitive exams. Among all the given components, which is the most common variety, obviously the type C variety is going to be the overall most common. It is going to be overall most common. Now, just to get perspectives right, because we have dealt so much about it, if I say what is the genetic component, or I can say the gene mutation associated with the tracheoesophageal fistula, the answer is going to be the NMIC gene. Again, this is your question that they usually ask you in a competitive exam. This is the question that they usually ask you in a competitive exam, right? Now, we'll talk about the clinical presentation and then we'll try to build across it. So talk about a clinical presentation of a baby presenting with tracheoesophageal fistula, because usually you will see the type C variety. So I'll be talking about the clinical presentation of a type C variety. We'll talk about a clinical presentation of the type C variety. So let's understand the type C variety. Now we already know that in a type C variety, you have the trachea, which is going to be absolutely fine. So this is the orientation of the trachea. This is the tracheal bifurcation that you have. These are the tracheal rings which we have. And we know here there will be an esophageal atresia with tracheo-esophageal fistula. The fistula will be from the lower communicating part. So let's say this is the upper atricial segment which is present here. The lower part of the esophagus is communicating with the trachea, and this is where you have the stomach, right? So this is the usual component that is going to be present. Let's see how does a baby will present to you. Now, when you talk about it, the usual age of presentation is going to be day 0 or day 1 of life. Now, here's a very important and a beautiful concept in GIT, that if you have a frank obstruction, example like atresias or imperforated segments, or like, exactly completely obliterated segments, like best examples are atresias. If there is a frank obstruction, all babies will present within the first day of life. If there's a relative obstruction like mucosal narrowing, stenosis, all that, they will usually present after 1 month of life. Example like CHPS, congenital hypertrophic pyloric stenosis, will usually see after 1 month of life. So here's the concept. Any baby who has a frank obstruction will present to you on day 0 or day 1 of life. Any baby who have a relative obstruction like narrowing or stenosis will usually present after 1 month of life. So here I have a baby on day 0 or day 1. At the day 0 as well as day 1. So what will be the complaint that you will be seeing across here? Now the complaint is, as soon as the baby is born, the first thing you will notice, you'll try to feed the baby, but even before you try to feed the baby, there are a couple of things that are going to happen, right? So we'll go in a chronological order that to see what is going to happen. The baby is born. As soon as the baby is born, the baby will be given to the mother for the breastfeeding, and we'll try to feed the baby. Now, every time the baby is being trying to fed, right? Every time the baby is trying to fed, the milk will go into the mouth, from the mouth into the esophagus, and there is nowhere else to go. So all that milk is going to pull into the esophagus upper segment which is there, and then immediately revert back. Now this is the first thing that you will notice, that there is repeated, there will be presence of repeated regurgitation. There will be repeated regurgitation of all feed. When I say there is repeated regurgitation of all feeds, I do not mean I'm going to feed biryani to this kid, but then every single feed that you attempt is going to revert in this. Now, obviously, there's multiple times the patient is going to cause this. Repeated regurgitation of feeds are going to happen. Now, problem is when it regurgitates, now some amount of feed that has been regurgitated, as it has been regurgitated, some amount of feed can also go into the trachea and result in aspiration, right? So this is another thing that you need to consider. For now, remember, there's repeated regurgitation of all feeds. Baby produce more amount of saliva. For a normal baby, the saliva would have gone into the mouth, from there into the esophagus, then into the tummy and gone back. Done. But here what is going to happen? All that saliva that is going to come from the mouth is now going to pull up into the esophagus. As the entire esophagus is now going to be pulled up, what is going to happen? There's no other space for to go. Then you will see the saliva will now start to pop out and start leaking from the angle of the mouth. So another very, very important pickup point, there is continuous drooling of saliva. There is continuous drooling of saliva, right? So there is repeated regurgitation of all feeds, and there is continuous drooling of saliva. Now, as you can see, the saliva that is going to drool out, some amount of saliva will froth down and then go into the trachea. Now, as you can see, the feeds are going as well as the saliva is going. Another finding that you will see, whenever the feed is being attempted, whenever the feed is going to be attempted, you will notice, with respect to the feeds, every single time the baby is fed, there will be coughing, and cyanosis. There is coughing and cyanosis during feeding. Now this coughing and cyanosis during feeding, it usually occurs because of the aspiration, and this is an indication. Now there is a aspiration of food, and I can say this will result in aspirational pneumonia. This can result in aspirational pneumonitis and also result in pneumonia, which will now going to result in respiratory distress. So these babies will also present to you with respiratory distress. because of the aspiration, right? So there's repeated rejection of all feeds, there's continuous drooling of saliva, there's coughing and cyanosis during feeding, and the baby will also present to you with respiratory distress because of all this. Another very interesting thing, as every single time the mother is trying to feed, the baby is not able to accept any feeds. Because the baby is not able to accept any feeds, what is going to happen? We expect the abdomen to be collapsed because there is no food in the tummy. But what is contrarily happening is, you will notice every time the baby is going to breathe, the air goes into the trachea. As the air travels into the lungs, some amount of air via the fistula is now going to go into the esophagus, from there into stomach, and you see the air is going to get accumulated in the stomach. Now, as the air gets accumulated inside the stomach, there will be distension. So another finding that you will see in these babies is going to be presence of abdominal distension even without feeds. There is presence of abdominal distension, and this abdominal distension is there even without the baby is being fed. So what are the symptoms you have? Repeated regurgitation of all feeds, continuous drooling of saliva, there is coughing and cyanosis during feeding, abdominal distension, that is because of the air that is going to enter from there. Now, one of the reasons that you have to suspect these cases is of the following order. Number one, look at the age. That is going to be day 0 or day 1 of life. Baby is not able to be fed, and you can see one of the most distressing thing that I can notice in this baby is the respiratory distress. Now, this respiratory distress is because of aspiration, and I have to address it. I do not have an option, right? Now, what is going to happen is, I'm not going to look for diagnosis. I have a day 0 baby with all these features. I know that the content is not moving down, right? There's some sort of an obstruction. I do not want, when this has been thrusted out, I don't want every time the baby is throwing out the saliva, I know if it is coming into the mouth, it will go into the trachea as well. So my immediate thing is, I should not allow this saliva to go into the trachea. I can stop the feeds, but I cannot uh, stop the salivary secretion. So in order to do that, what I will do is, as an immediate maneuver or an immediate step to counter these problems, as an next immediate step, as an immediate measure, what am I going to do? Now, as an immediate measure, I am going to insert a nasogastric tube, which is also called as the Riles tube. I will insert a nasogastric tube or a Riles tube and then connect it to low pressure suction. I'm going to connect it to a low pressure suction. Now, the objective here is to prevent saliva from pooling. I'm preventing the saliva from pooling into the esophagus, because if you are not preventing this, this is what is the culprit, which is going to result in aspiration. I have to prevent the. So all that I did is put an nasogastric tube, connect it to a low suction pressure, and allow that saliva or the secretions to be taken out. Now, once you have done that, now the baby has presented with respiratory distress. I would like to evaluate. So we'll take the baby for investigation. Now, when you talk about the investigations, in general, when you talk about it, now because the baby has presented with respiratory distress, it is no brainer that I will get an immediate X-ray to see what's wrong with the lungs or the chest. For my surprise, what is going to happen is, when we take the X-ray, we normally expect the nasogastric tube is still in the body. I expect that to be in the esophagus or inside the stomach, because I have pushed it completely. For my surprise, because we know there is an esophageal atresia, right? You see, this is the trachea which is present here. This is the tracheal bifurcation that you see. I'm seeing in the radiographic image, you have, this is the upper esophageal atresia. This is where the fistulous tract is here. So you will see the air shadow continuing here, which is going to be quite distensive, and you see an extensive air shadow in the stomach. Now, the nasogastric tube that we have pushed, it has gone into the esophagus. Now, because it is not going to go anywhere, it is going to coil inside the esophagus. Now, this coiling of the esophagus can be visualized on an X-ray. So the first finding that you will see on an X-ray is the coiling It is the coiling of the nasogastric. Now, logically thinking, if the nasogastric tube is coiling, I know there is something which is not allowing it to move across. But a babies में lateral की जरूरत नहीं है. It is not a foreign body that you are looking at. You can take an AP view. You can ask the baby. You can't have babies in various positions. A day 0 or day 1 baby. All that you can do is just put on a bassineter, take an X-ray, and you know where exactly it is. That's it, right? So the first thing I did is to put an X-ray. Now, the minute I did that, I now know there is some form of obstruction. To confirm what is it, I would like to go ahead with the contrast studies. The second, to confirm the diagnosis. To confirm the diagnosis. I know there's some obstruction, but how do you know the obstruction status? I will do a contrast study. I will perform a contrast study. So I will give this baby a small amount of contrast to swallow and see where exactly the contrast is going. Now, when you talk about the contrast study, always we are going to give a water soluble contrast. So here I would prefer giving a water soluble contrast. And there has been debate that what is the best contrast that you can give. Now, to settle the debate, I can say the best contrast is going to be iohexol. The best contrast is going to be an iohexol. If this is not given in the option, let's say if they ask you, is there any other contrast, then you can also give dinosol. Either you can go ahead with iohexol or dinosol. That is the contrast imaging that you can do. So what is going to happen is, again, if you look at the same picture, this is the trachea which is present here. Again, the same component here. And you see that this is the atricial component, which is here. And this is the lower part, right? Nothing spectacular about it. Now, when I give the contrast, you see the contrast will now go and pool into this esophagus and will not go anywhere else. So you can see the pooling of contrast. So what is the finding that I'm going to get? I'm going to get pooling of contrast. I'll see the pooling of contrast in the upper esophageal segment. I'll see the pooling of contrast in the upper esophageal segment, telling you that is an atresia which is sustained. So what I did the X-ray first. On an X-ray, I saw the coiling of nasogastric tube. To confirm why it is coiling, is there any obstruction? To confirm the obstruction, I did a contrast imaging. I gave contrast for the baby to swallow. That iohexol contrast goes and gets pooled inside. Now it is going to get pooled inside. Now, sometimes you can give the contrast and that contrast can simply go into the stomach, right? What is the best example? It is your H variety. So if you ever encounter for H type, so when you're going to evaluate for the H type variety, for the H type, which I hope everybody remembers it, we just discussed, in the H type, everything is fine. There is only a fistulous connection. So in an H variety, this is the tracheal rings which are present. And you see this is the esophagus. The lumen is absolutely fine, but there is this atricial component. I mean, there is this fistulous component that is present. If I give a iohexol contrast, if I give an iohexol contrast, the contrast will simply go into the stomach and sit. Obviously, some amount of contrast will go and sit into the trachea also. So this is another way that you can, basically look across it. But then if I say, because it's not stopping, it's not pulling, it might not give me the diagnosis. So what is the best? So here for H type, I have to combine two images. I have to go inside the trachea and look. I have to go inside the esophagus and look. So it is going to be your fiber optic bronchoscopy with upper GI endoscopy. You club these two, and this is the best investigation to evaluate for your H type. So FOB stands for fiber optic bronchoscopy. It's a flexible. We have the fiber optic bronchoscopy with upper GI endoscopy. This is going to be endoscopy, and this is now going to tell us what problem you're dealing with, right? When we look at the whole investigation, we started with a basic X-ray because baby had a respiratory distress after putting a nasogastric tube, and we found there's coiling on nasogastric tube. To confirm why is it coiling, I put a contrast agent. The contrast is not able to go any further, confirming it is type C variety. And then if there is an H variety, how do you confirm it? Because when you give the contrast, it usually passes away. The contrast is not a very good detailing here. So what we'll do is you do a fiber optic bronchoscopy with upper GI endoscopy. With an upper GI endoscopy, right? Now, in the contrast of it, this once you have diagnosed it, let's talk about the management, right? Now, once you have diagnosed this as the tracheoesophageal fistula or atresia in this context, you need to understand that every baby of TOF is known to have other congenital disorders. So, what are the other congenital? What are the other congenital disorders associated with tracheoesophageal? So the other congenital disorders which are found to be associated, the other congenital disorders which are found to be associated with tracheoesophageal fistula can be remembered by a small mnemonic, and that is what we call it as the VACTRL. This is what we call it as VACTRL. Now V stands for vertebral body defect. So always check for the vertebra in these babies. A stands for anal atresia, or I can say anorectal malformation. Anorectal malformation. A stands for anorectal malformation. C stands for cardiac abnormalities. Now, when you talk about cardiac abnormality, the common cardiac abnormalities that you will come across here is going to be patent ductus arteriosus or the ventricular septal defect. The PDA or the VSD are the usual disorders that you will see across here. Now, obviously T here stands for tracheoesophageal fistula and E stands for esophageal atresia. Now, as I told you, every patient of tracheoesophageal fistula is known to have atresia until unless proven otherwise. So that stands strong here as well. R stands for renal abnormalities. Now, when I say renal abnormality, they are usually associated with horseshoe kidney. They are usually associated with horseshoe kidney or worst case scenario, renal agenesis. That the kidney is not even formed. Renal agenesis means kidney is not even formed. And L stands for limb abnormality. Now, the commonest limb abnormality that I can tell you is going to be a radial bone hypoplasia. So the arms are short, so radial hypo. This is radial hypoplasia, right? So the other congenital disorders which are commonly associated with that of the tracheoesophageal fistula can be remembered by a small mnemonic that is called as VACTRL. V stands for vertebral body defect, A is your anorectal malformation, C is cardiovascular abnormalities, T is tracheoesophageal fistula, E is your esophageal atresia, R is renal abnormalities, and L happens to be your limb abnormalities, right? Now, I know that baby is associated with these conditions. Now, we have to look for management. Now, when you talk about the management of the tracheoesophageal fistula, now every management we have to define the goal, that why are you performing a surgery or what are you planning to do. Now, the goal for this, now goal for the surgery, number one, maintain the continuity, maintain the continuity between esophageal, and second, remove abnormal, communication between the trachea and the esophagus. They don't belong, it should not be there. Between the trachea and esophagus. So these are the two defined goals for the management of tracheoesophageal fistula. Maintain the continuity between the esophagus, and then make sure that you prevent that abnormal communication, because it is not supposed to be there. It is there. You have to just remove it, and that's the basic goal of it. Now, to achieve this goal, obviously, there's a lot of study. People have come up with various classifications. So, one such classification that we want to talk about is your Watterson classification, or I can say the Watterson criteria. The Watterson criteria is for the management of the tracheoesophageal fistula. So look at the Watterson criteria, and this tells you about the management. It tells you about the management of tracheoesophageal fistula. Now, according to the Watterson, the component that you will take into consideration, number one is the birth weight of the baby. It is the birth weight of the baby. Now, because I told you aspiration is quite common, you see whether the pneumonia has settled in or not, and then you'll talk about the management. So this is the line that we're going to think across. Now, a normal birth weight would be more than 2.5 kilograms, and that is what I expect the baby to have. If the weight of the baby is more than 2.5 kilograms, and imagine there is no pneumonia, then you have to directly take the baby for surgery. There is no brainer. You got your baby right where you wanted. Birth weight is good. There is no pneumonia. There is no respiratory distress. Take the baby for surgery as early as possible. The problem is if the weight reduces, right? So we say the low birth weight is less than 2.5, extremely low birth weight is less than 1500, and a very low birth weight. So when you talk about the birth weight categorization, I don't want you to goof up. We have something called as the low birth weight. We have the low birth weight. We say low birth weight if it is less than 2500 grams. Then you have very low birth weight if it is less than 1500 grams. And then there is extremely low birth weight, and that is going to be less than 1000. Right? So these are the weight line that you need to know. So this is the weight lines that you should know. So as lower the weight, poor is the nutritional status of the baby or the tolerance for surgery. So I have to differ, right? So the first one that I had, if the baby is more than 2.5, no pneumonia, take the baby directly for surgery. If the weight of the baby varies between 1.8 to 2.5 kilograms, now you have to see whether the pneumonia exists or not, right? So let's say plus minus doesn't matter. Birth weight is low. Start the patient on antibiotics. Start the baby on antibiotics, increase the weight of the baby, increase the weight of the baby, and then take for surgery. This is the plan of action that you will follow for these babies, right? So start the baby on prophylactic antibiotic, build the nutrition, build the nutrition. And for building the nutrition, obviously you have to take an access, right? And then take the baby for surgery. Now, the one which is going to be even more trickier, if the weight of the baby is less than 1.8 kilograms with or without pneumonia. I cannot do an upfront surgery, so I will do a gastrostomy. That is for feeding purposes. I have done gastrostomy for the feeding purposes, right? Now, this gastrostomy is done again to increase the weight. So this feeding, I have to get to my desired weight line. So this is to increase the weight of the baby. Then if pneumonia is there, treat pneumonia. If pneumonia exists, treat pneumonia and then take the patient for surgery. But here we'll do a delayed surgery. Here we'll do a delayed surgery, and that is the protocol that we follow. So according to the Watterson criteria, when you look at this, the management purely depends upon what is the birth weight of the baby. If the birth weight of the baby is more than 2.5, no pneumonia, surgery. If it is between 1.5, to 1.8 to 2.5, with or without pneumonia, start on antibiotics, build the weight and do early surgery. Here, we'll do a feeding gastrostomy, treat the pneumonia and then take for delayed surgery is what we follow for a treatment protocol according to the Watterson's criteria. Now, each individual will have its own management protocol. So we'll talk about how do you manage the type A variety. Now, let's say in the protocol for the management, so management of type variety. Now, the management purely depends upon what is the extent of the atresia, right? So what do you mean by the extent of the atresia is, if you take this as the representation of the trachea, this is the representation of the trachea that we have. And let's say this is the esophagus, which is having the atresia. This is the esophagus, which is having the atresia. And this is going to be in continuity with that of the stomach, right? Now, the objective here is the distance between the two segments. You have to see the distance between the two segments, that is your upper esophageal segment and the lower esophageal segment. Now, if this distance which we are talking about, if it is less than 2 vertebral body distance, if it is less than 2 vertebral body distance. Now, what do you mean by this is, when you take the X-ray, you will see the vertebra will be present here. You will see the vertebral shadows are going to be present here. So what you do is you measure both the components which are going to be present here, right? So this distance, if it is more than 2 vertebral body distance, you see, if you can see here, it is hardly crossing only 1 vertebral. If the atresia is here, if it is involving more than 2 vertebral body, then we will call it as long distance atresia. If it is less than 2 vertebral body distance, it is called as the short distance atresia. This is what we call it as a short distance atresia. For a short distance atresia, I am going to go ahead with primary anastomosis. A primary anastomosis over nasogastric tube. To do a primary anastomosis over the nasogastric tube, what do you mean by this is, this was the atresial segment that we had, going to be here. I will pass a nasogastric tube and I will anchor the nasogastric tube. Intraoperatively, I will feel that nasogastric tube and then I will open this end. So I'll make a small incision here, passing across here, and under the vision, I will open this part of the esophageal lumen also, and this is how you have present. So what I'll do is, I am now going to pass this nasogastric tube going from here, entering in all the way to the stomach. The reason why I want the nasogastric tube is, after the surgery, I want to feed this baby and I cannot feed because the anastomosis is done and baby tries to swallow, the anastomosis will give away. I don't want that to happen. So I will put the nasogastric tube and gently I will pull this up, right? Gently I will pull, there are two options. This is a very good point. There are two options. Either you can pull, so we can say this is the proximal end. This is the proximal end of the esophagus. This is the distal end of the esophagus. Either you can pull the distal end up or you can pull the proximal end down. What would you prefer? Most of us think you can take this up. We'll try to pull it up. But the problem is, the lower part of the esophagus is actually being supplied, or the mid and the lower part is supplied by the thoracic vertebra, as well as the short gastric artery is going to supply the gastroesophageal junction. Now, they're very short vessels. They are arising from the descending part of the thoracic aorta. The short vessels are giving, if I try to pull it, the blood vessels will break away. It will give away. I don't want that to happen. Just for the sake of understanding, I don't want to be more dramatic, but imagine if the trachea, your aorta is going, and this is the descending part of the thoracic aorta. So if this is, let's say here, which is going to just go across here. Let's say this is the descending thoracic aorta, which is present here, and it gives rise to these short blood vessels which are supplying to this part of the esophagus, right? This is supplying this part. Now, if I try to pull this up, because they're very short, they will break away, the vascularity will lose up. The upper part of the esophagus is actually supplied by the inferior thyroid artery. If you remember my thyroid lecture, I told you the inferior thyroid artery is a branch of thyrocervical trunk, which itself is a branch of subclavian artery. So subclavian artery is in the chest. So if I try to pull this, the supply is coming from here. Inferior thyroid artery is here, right? So inferior thyroid artery, which is a branch of your thyrocervical trunk, which is a branch of your subclavian artery. Subclavian artery is here, and the supply is coming here. Now, even if I pull it, it is pulling towards its supply. It is not going to hamper anything. So remember, whenever you're trying to migrate it, it is always the proximal end will be pulled towards the distal end, not the vice versa. Now, once you have done this, the eventual result is going to be this. So this is the nasogastric tube. This is gone here, which is sitting across here. You see, this is where the anastomosis is done, right? So this is what we call it as the primary anastomosis in order to create over nasogastric tube if it is less than 2 vertebral body distance. If it is less than 2 vertebral body distance, right? On the other hand, if it is more than 2 vertebral body distance, the same concept, you take it here. If it is more than 2 vertebral body distance, if it is more than 2 vertebral body distance, then we call this as the long distance. Then we call this as a long distance. Now, in a long distance atresia, I will not be able to make an anastomosis by directly pulling it, right? So what I do is, in a long distance atresia, I have to build in nutrition. So I will do a feeding gastrostomy. I will do a feeding gastrostomy. Now, when you have done the feeding gastrostomy, I will usually wait for 6 months, and after 6 months, I will review. After 6 months, I will see the distance between two ends have grown or not grown. So after 6 months of feeding gastrostomy, I am waiting for these two esophageal ends to grow. If there is presence of growth, or if there is no growth between the lumen end, right? You can analyze whether there's any growth or not. How do you analyze this? Is again by the X-ray, 2 vertebral distance वाला ही rule है. अगर growth present है तो distance between the two arterial segment will be less than 2 vertebral body. If not, growth नहीं है, it will be more than 2 vertebral body. अगर growth present है, nothing like it, go ahead and perform the esophageal anastomosis. Here you will do a esophageal anastomosis over nasogastric tube. What we did. If there is no growth, then you have to do a interposition, or also called as the transposition. You have to do an interposition or a transposition surgery. Okay? Now, what do you mean by this interposition or a transposition surgery? Is same thing as I told you. If the growth is not happening, this is the upper lumen that is present, and this is the lower lumen, and I have to cover this much amount of distance which is present here. So what I'll do is I will take any part of the bowel. And I will make an anastomosis between these two ends. So I'll open these two ends again. I will take a loop of the bowel and I will position the loop of the bowel between these two, along with its mesenteric end, because it requires its blood supply. I'll go ahead and make an anastomosis here. So whenever you position a bowel between these two ends, right? I have positioned a bowel to sit between the proximal and the distal end. This is the proximal end, this is the distal end. To maintain the continuity, I've put a new bowel, and this is what we called as a transposition or an interposition surgery. Normally, what are the loops that you can use, right? So I can use for transposition, I can use jejunum, I can use colon, left is preferred over right, and obviously I can do a gastric pull through. So I can also use stomach as a conduit. So this conduit that we have taken, this could be of jejunum, it could be of colon, it could be of stomach. But remember, in children, the most common in children is going to be jejunum, and the most common in adult, if you are doing such a transposition surgery, is going to be stomach. As simple as that. Okay. So I've taken this loop, interpositioned it, and done with the surgery. And this is what we do it with respect to no growth. Now, as I told you, the wait period is much longer here. It looks like the 6 months is actually a very long period. Now, how do you reduce or fasten, or I can say you can, you know, uh, growth has to be increased between the two lumens. So, in order to hasten the growth, that means so that this wait period can come down to less than 6 months. In order to hasten this, we have a device which is called as the flourish device. We use a device which is called as a flourish device. Now, what is the concept of this flourish device is? This is the upper esophageal segment, which is atresia. This is the lower esophageal segment that is going to have atresia, right? So what I want the distance to decrease between these two. So what I'll do is I will put a magnet here. I've placed a magnet here, and then I have placed a magnet here. Two magnets are pulled. So obviously when you place the magnets, each magnet is going to attract towards each other. Now, as this attraction goes stronger, you can see there is some amount of pull. So it's basically you're trying to pull these two lumens. So when you pull it, obviously the length will increase. So to fasten the growth pattern, this is what we do, which is called as the flourish device. And that flourish device puts you where exactly you want it. So this wait period can be reduced to 2 to 3 months. But again, not very popular technique, but we still discuss it for our exam purposes. Okay? So this is how you're going to manage your type A variety. So in a type A variety, it's a very, 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 very technical component. Consider every single thing that you have taken into flow and then managed our patient. That's what it is really important. The rest one, when we look at it, the other types management, when you talk about it, we talk about the management type A, then you talk about how do you manage your type B, your type C, right? So when you talk about type C variety, type B and type C, we know it, there are two fistula there. Then you have type D variety, which is going to be present here, right? And obviously the H type variety, or I can say the E variety. For all of them, we do a surgery, which is what we call it as the Cameron Hyatt surgery. So what is this Cameron Hyatt surgery? Now, Cameron Hyatt surgery is quite simple. Let's say this is the baby, right? I am going to put the baby into a left lateral position. So this is how the baby is being positioned. This is how the baby is being positioned in a left lateral position, right? Exposing the right side, right? I've exposed the right side. This happens to be the thorax which is present. And let's say this is the midline that you have, right? So the incision that we are going to place here is going to be a right posterolateral thoracotomy, right? So I will do a right posterolateral. So the incision that we are going to do is a right posterolateral thoracotomy incision would be given, right? So I'll do a right posterolateral thoracotomy incision. Now, why from the right side? Because if you go from the left side, no, you will get the aorta. Right side, you'll get the esophagus, right? So when you start from the left side, aorta comes first, then the esophagus. Right side, directly the esophagus will come. So right posterolateral thoracotomy. Now, once you're done, we are going to identify tracheoesophageal fistula. We're going to cut the fistula. Now, once the fistula is cut, I'm going to repair the trachea. I'm going to repair the trachea. And usually when you repair this trachea, we are going to use an absorbable suture material. And the absorbable suture material, the absorbable suture material, the absorbable suture material that you use is going to be, it is going to be PDS. And then anastomose, or the anastomosis of two esophageal end. Anastomosis of the two esophageal end over nasogastric. Anastomosis of the two esophageal end on a nasogastric tube. This is what we are going to do. Now, whatever we said, if you look at the diagrammatic representation, what is going to happen? Now, this happens to be the trachea that we've been talking about. Let it be any variety. I'll take the type C variety, which is easier for us to comprehend. So in type C variety, you see this is where the tract was formed, and this is how it is there, right? So the first thing I'll do a right posterolateral thoracotomy, reach it. But before that, I will insert a nasogastric tube in the upper part. Intraoperatively, it is going to help me guide it. I'll show you how. I will identify this area, that is the tracheo-esophageal fistula, and I am simply going to go and cut this part. I'm going to cut this off. Once I cut it, I will take the PDS suture material and I will repair this trachea. That is, with the help of PDS suture material, I have repaired the trachea. Now, once I have repaired the trachea, the esophagus is now open. So what I'll do is, I will take this esophageal end. I will take this esophageal end and then align with that of the lower part of the esophagus that is present here. Now, once you're done, your result that you have, the repaired part of the trachea will be absolutely fine, which is here. The trachea is being repaired. I have no problem with the trachea. So this is the repaired end of the trachea that we had, and the tracheal rings, everything is fine. There is no problem at all. So here everybody is happy. This upper part of the esophagus there, which is having the nasogastric tube, I will create a small opening here. Now once I create a small opening, I will take the nasogastric tube, which is here. Because I will able to fail it, I will insert the nasogastric tube through it, and then I will position it in the stomach. Now once I do that, align it, make an anastomosis, the same thing is happening. You see this part is going to be stretched down. This is the fistulous segment that we have mobilized, and now it is going to go with the stomach. Yeah. I have positioned my nasogastric tube, which is here, and now we are making an anastomosis. Once the anastomosis is done, which is to be here, and this is now right. So this is how you do. You identify the tracheo-esophageal fistula, which we did so. We identified the tracheo-esophageal fistula. We cut the fistula. We repaired the trachea with the PDS material, and we anastomosed the esophagus, and bam, you're done. Right. So this is how you repair your tracheoesophageal fistulas, and this has given a fancy name just for the sake of understanding, called as the Cameron Hart surgery. Right. So the first name surgery that I've introduced to you in GIT is in the tracheoesophageal fistula. That is your Cameron Hart surgery. Right. So this is how we do it in GIT. Yeah. Any questions? Any feedback? कोई सवाल, कोई शक? I know आजकल लेक्चर थोड़ा सा खींच गया because initial 5 minutes there was a small glitch. To compensate, we have done this well. All right. So we have no questions. Thank you so much for joining. Tomorrow, come back again at 9 o'clock to do another small topic in the esophagus, and bit by bit by bit by bit, we will complete our GIT. Thank you so much for joining. Thank you, Mehak, for such kind words. Your motivation means a lot. Yes, again, a lot of people have been asking, sir, where do we get the notes? Where do we get the notes? Our MedEd channel will get the notes, but at the same time, if you want to access it, this is my Instagram and Telegram, called as the Surgery Guy. You have any questions, any queries, reach out here. This is for both Telegram as well as Instagram. This is my name, that Dr. Sandeep Seeram Reddy. Soon after the class, you can find the PDF here, and this is for both the Telegram as well as your Insta. In both, you'll find this, right? So all the PDFs, questions, answers, details will be found on this channel. It is the Surgery Guy by my name. Any questions? queries, feel free to reach out anytime you want. Thank you so much for joining. Good night. Take care. Bye bye.